much, Sophie. So yeah, I think I'm wearing a couple of different hats here. So I'm wearing a sort of NHS England a paediatric epilepsy oversight group hat, which is why I'm providing a background to the mental health pilots that are currently in place across the UK. But also there's going to be a little bit of history of how we got to this point, which then sort of involves the kind of Open UK sort of journey around regional epilepsy networks. So the first thing is that I've learnt from Sophie today. So when I walked in this morning, Sophie was talking about an incredibly optimistic perspective about our journey towards improvement of care for children and young people with epilepsy. And I think what I might have been guilty when I was just designing my thoughts here of presenting it as kind of like, you know that meme where Sideshow Bob is walking through a whole load of rakes on the floor, and every single step he takes, then the rake whops up and bashes him on the face, and there's a yelp of disappointment. Then there's another rake, and so I think that was the kind of sort of series of obstacles that I was going to present in this preamble. But what Sophie has moved me towards is actually this is a journey, and there's a lot of rakes on the way, but at the end of it, our patients get great care. So that's the thing. We're all on a journey and we're all making great progress. So I need to just be a little bit more Varadkar and a little bit more sort of optimistic. So we're going to get there, but I might have retired by the time we do.
Richard,
yeah.
the first rate for today is to stand a little more to that side.
A little bit more. That's true. Although I haven't got any slides, so I can just dance in the middle. Okay. So how have we got here? So I think along the way, so there might be a couple of places where I use a sort of booming voice that will sound a bit like the voice of God, but in fact it's probably actually the voice of Dunkley. So you might think that I have developed some kind of insight into how we engineer change and improve quality in the NHS. But the answer is there's definitely no answer to that question. There's definitely no answer to that question. So you were right that diabetes did well, and we've tried to follow their path, and that path is totally closed to us. So however diabetes did it, we definitely can't do it in that way. And in fact, if you even mention diabetes, then people get very switched off very quickly. So, okay, let's go back 20 years. Surely, in order to improve quality, you just have to define it. So in 2004, there was NICE guidance that stated that routine access to mental health screening and intervention should be routine for children with epilepsy. So that's all you need to do, right? We're completely triumphant. We're going to have exactly what we want. But no. That's the voice of Dunkley again. So underpin it with more evidence. Okay, so Isabel Heyman came here to this conference maybe 5 years ago, and she presented a lot of data that told us that routine access to mental health care for children and young people with epilepsy was absolutely crucial. And her brilliant data, I think this is the most amazing research that's been done in epilepsy, which showed that over 5 years, if you fantastically treat children's seizures, their quality of life doesn't improve at all, whereas if you treat their mental health problems, then the quality of life massively improves. So data that really confirms everything that we know. So that should do it, right? No. So I did a survey with Jonathan Holland within Open UK that suggested that almost no units in the whole of the UK were routinely screening for mental health disorders. So we thought, okay, we need more data. So the brilliant Epilepsy12 data. So a couple of years ago, this showed us that only 9% of units were routinely screening for mental health disorders. So that gap, it turns out, doesn't drive change. So demonstrating that huge gap doesn't drive change. So we thought a few years ago maybe it would help if we got NHS England to acknowledge that this was good practice. The voice of Dunkley again. We argued that routine access to mental health screening and intervention should be part of the best practice tariff, the payment tariff, and we got it in. Fantastic. But it came with no new money and didn't increase participation in routine access to mental health screening. So now you have to ask the big guns. Okay, audience, who are the big guns? Who are the big guns? Sophie, who do we listen to, particularly at Open UK conferences, and they tend to present first?
Patient, public, carer, population.
Yeah, exactly. It's basically the Epilepsy12 youth advocates. So we need to wheel out the big guns here. So they've told us every single Open UK conference that we've ever had that the consistent message is that this is the biggest single priority for children and young people with epilepsy. And we've told this to national clinical directors for children and young people serially across the way. And they're all completely persuaded by it. They all completely take it on board, but it doesn't move the dial one jot. Okay, so that doesn't work. So you need a broader stakeholder voice. So the UK Epilepsy Programme Board, you know, with added Helen Cross goodness and all of the charities and nursing and a unified voice, you know, a really loudly spoken message. This will get us going. And we got, that meant that we got, you know, mental health into the NHS England bundle, the bundle of care. So it's one of the big 4 themes. So we're really getting somewhere. So what do we need to make this happen, we say to the integrated care boards? We need new money, they say. Right, okay. Do we really? What about cost effectiveness? So we just heard a little bit about health economics. We have the PAVE study from Glasgow. We have some not yet published data from mice, but which they have actually presented. And it tells us that mental health screening and intervention is cost effective. So you remember that Isabel Heyman came to this conference 5 years ago and said that she thought that this could be cost neutral. Now she's done the research. She literally has, you know, done the mice trial, which has shown that mental health screening and intervention is cost effective. So you move your resources around. You don't need any more resources, but children get better quality care. So you'd have to really hate children in order to not do it, wouldn't you? So surely that will do it, right? Maybe. So NHS England Oversight Group says, well, how about we pilot it? How about we pilot the PAVES approach? We're going to do some mental health. We're going to find out what practical difficulties there are with this. We're going to see how much it costs. We're going to put it into practice with a little bit of new money across the UK, with each NHS England area having a pilot, and we're going to see how that goes. And then maybe we will be getting to the end of the rakes. Or maybe there may be further, but the point is that these pilots are going to take us closer to where we need to go. So it's rake after rake after rake, but we're getting there, and the mental health pilots are crucial to that. So I've used a terrible analogy already, but I was thinking that, so this is a bit like a jigsaw puzzle, except it's one that was designed by Enid Blyton, and the jigsaw puzzle keeps redesigning itself and getting bigger. And every time you find a piece, then you need to find another one as you go. It's probably a terrible analogy, but anyway, if you like Enid Blyton, then it'll work for you. So I guess the pilots are trying to provide the sort of ephemeral answer to the question, how do you improve quality within the NHS? So that's what we need to learn from them, and it's only one piece of the jigsaw. Thank you.